Hello and welcome to the episode 10 of Straight from the Hip. I'm Benoy Mathew, advanced practice physio and based in London, UK. And join me is Callum, my friend, a hip specialist all the way from Perth. And this episode, we are sort of continuing from the theme. So in episode 9, we looked into early identification. And obviously, identification is not much of use unless we manage it really well. And that's what we're going to delve in, looking into conservative management. How can we get our patients, get them going and also preserve the joint and also not wait till they need surgical input. So a lot to unpack for this session. So what have we got, Callum, on this episode looking into the conservative management of early hip OA?
Yeah, I think we know that hip OA is one of the leading causes of disability worldwide, isn't it? But not just hip OA, just osteoarthritis in general.
Osteoarthritis.
Yeah. So what we're going to go into today is what conservative management are we going to do early? You and I can have a chat, if you like, Benoy, on what sort of things that we would focus on in those early days, because that's quite often the hardest bit. What the role of exercise and load management has, why education and language is so important. So Benoy and I have spoken off camera just before this episode, and we think it's really important for us to talk about the education, the language, and how we're communicating with patients here. What are some of the common rehab mistakes? This would be my anecdotal, I guess, Benoy, what you've seen, what I've seen, and how can we as musculoskeletal practitioners help patients to stay active and confident? I suppose they're the sort of top things we'll cover in this episode. Now, Benoy, we spoke about why conservative management matters so much, and you have really been powerful here in saying we need to talk about education, we need to talk about language and labels. So what is the kind of thing that you see when patients come in? Do they come in with a label? Do they come in with certain concerns or fears? Do they catastrophize? Have you heard that they've been told something by an orthopedic, a GP, a prior colleague, and it's induced fear? Do you see that?
Yeah, I think this is sort of important right from the beginning, is to set the scene. Let's give an example. You got like a 48-year-old middle-aged male who's very active, bit of running, done a lot of football or rugby when he's young, has this sort of grumbly hip and going for a while, and then most people jump into MRI, especially in private practice, and they come with an MRI which comes with a long list of problems. It says extensive labral tear, some chondral cyst here, some tendinopathy, and it comes with a lot of information, and that can create a lot of fear. And sometimes simplification is a good thing. So sometimes, my job is to sort of simplify and say it's just early osteoarthritis. All the other things are not really relevant here. So sometimes osteoarthritis can be a good label rather than going into a million different differential diagnoses. So most of the time I see patients, they're not fresh, they have really been around the block. And the danger is sometimes people overcomplicate osteoarthritis. And if you go to an MRI, people with osteoarthritis, you're going to find changes in the labrum, the capsule, the subchondral bone. And, you don't need to look at high definition of the osteoarthritis. We know osteoarthritis is a pan joint disease. It affects the whole area. And sometimes it's a big relief, which was quite surprising for my initially is most people don't tend to have much fear. It's mostly when they think of the wear and tear, the cartilage losing out, or will I need a hip replacement? So one of the key things which we'll explore is the fear element there, which using bad, inappropriate language here. So I think osteoarthritis on its own, it's not, in my opinion, it's not a harmful term, because that's something which people are aware of. But most public know about osteoarthritis than tendinopathy, and most people know that it's something which happens with age. But we have some myths and some sort of misconception. One is that I'll definitely need a replacement very soon, or it's bone to bone. So what do you think is some of the harmful languages or terms which we should be really be avoiding? Or on another extreme as well, we find people where they stop everything. They stop running. They don't do anything. They're just waiting for the hip replacement to happen soon, and they feel like it's pretty much a useless case. So I find people in the extremes here. They totally shut down, or they don't move, or they feel everything is useless. I just have to wait for another 15 years when I need a replacement. So that can be quite painful, in my opinion. So what's your thoughts on those sort of language and also those extreme patients?
Yeah, I've seen it quite a lot more here. I think I said in our last episode, Benoit, that a lot of people in private practice here come to me with scans, or I get sent a report by a doctor somewhere, which the patient has got as well. So they've already built up a belief of these scans, and I wrote some quotes down on some of the things that I hear. So you've got the hip. I don't know. This could be a 40-year-old, and someone has said to him, "Oh, you've got the hip of a 90-year-old."
Yeah, that never helps anyone, isn't it? Yeah, yeah.
And then they'll say, oh, look, your hip is looking pretty worn out. It's bone on bone. Look, see how you go with physio for the next few months, but chances are you're going to need a hip replacement. Other than that, nothing else can be done. The other big one, which you'll love, Benoy, because you see a lot of this demographic, is stop
Yeah.
running. So we get
Yes.
obviously runners here, and they
Yeah.
go, just stop running. Running is going to wear out your hip. It's going to make things worse. It's going to, I don't know, they might say, look, you've got a millimeter left of cartilage, and the running is going to
Don't wear
wear
it
that.
out. Yeah. Yeah.
Yeah,
Yeah.
that is look, infuriating to hear, because we know, Benoy, that running is actually very, very good for our hips, for our knees as well. You know, we're not
Yes.
saying that someone that comes in with hip osteoarthritis, for some people, it's not going to be appropriate for them to keep running. We might have to say, look, until we get the symptoms to calm down, we're probably going to have to ease up on running. But there's lots of other forms of cardiovascular training we can be doing, you know, like swimming, rowing, a ski erg, a cross trainer. We can do all of that. But there are other people where maybe they don't have quite so much of an irritable hip and they can keep running. There was a great study, Benoy, which I think I wrote down for us back in 2017,
Yeah.
and it some really interesting ideas. And they found that running is actually could actually play quite a protective role or a protective effect on not just your hip joint, but your load bearing joints, in that it can improve cartilage nourishment, it can improve synovial fluid circulation, it can stimulate chondrocyte activity and improve your cartilage thickness as well. So there's actually really good biological effects that running can have on your joints, like your hip. So I think that's one where you see a lot of runners, but particularly Benoy, I think that's a big myth to debunk, and not be saying to people, your hip is wearing away, you've got the hip of a 90-year-old, stop running, it's going to make it worse. Those are big myths that
Yeah.
is actually
Definitely.
trying to kind of bust those through with a patient in
Definitely.
front. Because as you say, everyone knows what osteoarthritis is. They sort of know
Yeah.
what it is. They've associated it with degradation and wear and tear and things like that. And that's the bit that frightens them. If we can demyth that, debunk that, it's amazing seeing the elation on their face, and they smile and you see their shoulders relax and they go, oh, so I can keep walking, I can keep running. It's like, yeah, of course you can.
Yeah.
Yeah.
Yeah, I think yeah. So let's set the scene here. So I'll also share my thoughts here. So you got like an active male in late 40s, a fresh diagnosis of hip OA, either confirmed by X-ray or MRI. Quite does a bit of 10K, half marathon running, a lot in the gym. Coming to see you, bit disappointed, bit not in the right place. So no point jumping into the exercise till you get them mentally on board. So you got this patient in your clinic, come to you for a second opinion. How would you sort of get them on board here with the diagnosis of osteoarthritis? What are the key, few points you want to drill them early, sort of, so that they understand this is not something it will lead to a rapid decline or something they can't train. So I find if you don't set the scene and get the compliance, there's no point rushing into the rehab. So what would you do for a patient like that in your clinic?
Yeah, that there's these fears around what osteoarthritis means. Again, it
Yeah.
depends on the context of how much they want to know. But I think we try and explain that osteoarthritis is a whole system sort of issue, if you like. It's something that very commonly happens, the same as getting grey hairs, the same as getting wrinklier skin as we get older. Our internal tissues, the same sort of thing happens. But it's trying to explain to them that this doesn't mean that you can't keep being active, you can't keep exercising, you can't keep running. If we use sorry for the wrinkly skin, let's use that, Benoy,
Yeah.
the wrinkly skin as we get older. Does that mean we tell someone not to sit in the sun anymore? Of
Yes.
course but we just say to them, look, put your factor 50 on, just be safe. You can
Yeah.
still go out and enjoy yourself. We don't do that.
Yeah.
So if we use that concept of slightly wrinklier skin as we get older, that our tissues and joints change as we get older, we shouldn't then say to them, stop walking, stop running, stop going to the gym, don't do a high rocks if that's what your goal is. So I suppose it's creating a bit of analogy like that all of these things are possible, because we need to change or try and change the expectations and the trajectory of their life.
Yeah.
And as you said, that education is the most important thing. And sometimes in that initial consultation, sometimes we don't give any exercises, or I don't.
Yes. Yeah.
Sometimes there can be this belief, certainly in private practice, that from that initial consultation, everyone needs to be given an exercise
No.
to do.
Yeah.
Sometimes, but you need to think, what's the priority for this consultation? And what's the priority for this person in front of me right now? Maybe the exercise isn't important on this first bit. Maybe there's a lot of yellow flag. There's a lot of kinesiophobia. There's a lot of catastrophizing. They're actually reducing what they're doing. They're not becoming very active. To me, that's a bigger problem, that they're not even moving. They're not active anymore. They're very frightened. Let's address those things. Let's spend this 45 minutes, this hour, providing that education and encouraging them to keep being active. to say, look,
Yeah.
this isn't bone on bone. Your hip isn't crumbling away. Yeah, I think that education, that's my buy-in. I wouldn't say I've got a script. I would say
Yeah.
sometimes use some metaphors, or sometimes use some anecdotes, and I use the wrinkly skin in the sun sort of idea.
Yeah.
But yeah, that's probably how I would try and get that buy-in. That first consultation is very important on the education for me, less so on the
Yeah.
exercise.
Yeah, definitely. I think is the making them clear of the diagnosis, and there are 2 3 points which sort of mirrors what you said. I think the main thing is to move away from that diagnosis of just on cartilage. So
Mm,
osteoarthritis is just not a cartilage problem; it's a whole joint disorder. It's looking at your, a chemical reaction, synovitis, your muscle strength, and also looking at the general health as well. So saying to them, osteoarthritis is something which we can manage very well in most cases with exercise, weight management, lifestyle changes, and it's not going to be inevitable decline. A small percentage of them will need a replacement. That's true, and we know that hip replacement is one of the best surgeries out there for the right person. For patients who need it, and we'll discuss that. What's the criteria before we refer on to surgical opinion. And the other point is movement is safe and is the best thing you can do. It's not harmful. You're not going to wear away by doing exercises, even things like running. If you've got the fitness, if you've done a lot before, and if you're not in a flare up, I think running is the best thing and might not be appropriate for everyone, but there's no need to stop, especially if you're done for that. And the third point, which we'll talk, I'm sure, is flare up is extremely common. With any chronic conditions, you're going to have some bad weeks here and there. That doesn't mean like you're declining. It's just part of, you might have maybe have twice a year. That's quite normal. And we give them a plan, what to do in a flare up, what are the things to do, what modification to do in the gym. And also you don't need to put your life on hold till you need a replacement, because you just that's not a good use of your time and strength. If you don't do much, you're going to decline. So I think it's that positive reinforcement on movement is medicine, and we really need to get those muscles. Important to give more nutrition to the cartilage, and also that's the best way to nourish the joint. So I think trying to be positive, and if you don't get the buy-in, if they have the fear of exercises, no point giving them exercises. So I think that sometimes can take a good 30 or 40 minutes to go through the 3 points. So I think that goes nicely to here is, in your opinion, what does good exercise rehab look like in early OA? Somebody like in the late 30s to 50s.
yeah, I'm going to go the other way, Benoy, if that's all right. I'm going to tell you what
Start
I'm going to go. What, in my opinion, this was what rehab should not look like to
like,
begin with.
okay. Mm,
So I'm going to on its head a little bit.
yeah.
Some of the biggest things I see are just generic exercises.
Mm.
Just I can't
Not
think of any
tailored.
other way
Yeah.
than that.
Yeah.
Yeah, there's no
Yeah.
reasoning behind it. There's no why
Yeah.
have you given this? And
Yeah.
if you've given that exercise, why have you given it at that dosage? I think sometimes we can forget, because we're typically in the physiotherapy business. We're not in the business of invasive treatments, right? I know, Benoy, you do injections and things like that, but I suppose
That's not our bias, really. We are more conservative first. Yeah.
yeah, no, the physiotherapy world, where we are about conservative and non-invasive treatments. But sometimes we forget that we are giving a dosage of something. We are prescribing something in the same way that a GP is prescribing medications, or Benoy, I know you're prescribing injections, and you have to give a lot of thought into what injection, how much, and where landmark it goes. With exercise, we've got to carry that same concept. And okay, we've got to think of an exercise here, but is that exercise appropriate? And what's the dosage that we're giving it to? So sometimes we'll use clamshells, Benoy, because I know you love a clamshell. You do them
Yeah.
every morning, right? When you get up out of
Yeah.
bed.
Yeah. Yeah. With the nice purple band. Yeah.
Just to be clear, we don't mean to
Yeah.
bash shells. Loads of people are going to go, oh, they're awesome. Look, it's an exercise, but something that we won't talk about today. Benoy's posted on this on Instagram and LinkedIn, so have I. But clamshells are not a fantastic exercise for people with hip pain, just generally speaking, but certainly intra-articular, like hip osteoarthritis. And the idea of what the clamshell is doing in targeting the glutes lateral hip complex, that was its original design. We now know that it's certainly not conditioning what was originally designed, what it was originally designed or thought to be conditioning. But we use that as an example, that if people are just picking random exercises and random dosages and it's not reasoned, that for me is an issue, because again, it just comes back to poor clinical reasoning into why we're giving what we're doing and the dosage, etc. Don't be prescribing random stuff without purpose or reasoning. So good rehab for me, it needs to focus on that individual in their individual function. So
Yeah.
in our last episode, Benoy, you mentioned hip extension. I think it was you that mentioned it, that people can lack hip extension not because they can't do it, but when they're walking, they're just guarding. They're guarding their hip, and part of the central nervous system thinking or adaptation to movement is let's reduce that hip extension because then it shouldn't provoke the hip so much. Naturally, what will happen is that pain inhibition and activity modification means you might find that hip extension strength has been reduced from that. So you then got to think, okay, I need to address this hip extension. Maybe this person can't do hip extension in standing or single leg standing. So you might have to get them laying on their side or on their back and prescribe it that way. But that's a reasoned approach. You found an issue or a strength deficit, and you're finding a way in which you can target that deficit without provoking the hip. That would
Yeah.
be the individualized exercise prescription, just as one example.
Yeah.
Low
Can I add
tolerance.
one thing? Yeah. One thing is, before I forget, is I find on the other extreme, especially young OA, sometimes I find people jump because they are active and young and they got a POE. I see them come in with ridiculous program like box jumps and Copenhagen's and all the crazy stuff where it's too highly, too aggressive when they
Yes.
have their initial phases. So you find this two extreme. One is inappropriate, underloaded, provocative. On the other side, we find it's too aggressive, too high impact, which is not appropriate in that early phase as well. So I think those two can really piss off the hip, and
Yes.
then they will say like the exercise is not working. Do you find that?
Yeah, absolutely. And actually, I'm glad you brought that up because this is a particularly passionate thing on my end from a sort of strength and conditioning background. Is I had a case not too long ago, not hip OA, but it was pubic related pain or pubic
Okay.
related groin. And part of their initial exercises was Copenhagen's, which you've just referenced there, Benoy. And
Yeah.
it was really upsetting their symptoms. And you look at that and you think, look, there's nothing wrong with the Copenhagen. It's a good exercise, but it's also a very hard exercise in terms of the demand that it's putting on the connective tissues and the traction stress it's putting on the pubic bone. It's just too much too early. It wasn't an appropriate exercise at that moment in time. And using that as an example, I think Copenhagen's are maybe overprescribed a little bit to address the adductors.
Yes.
And look, it's fine for mid and late stage, but in early stage, that wasn't appropriate and it flared symptoms up. So that was too much too soon. Box jumps was the other one that you gave. But then the other extreme, which I know you and I, Benoy, spoke about with FAI syndrome in our previous episodes, if you've got a high roxer or a CrossFitter coming in and they might have hip OA, and they're used to doing deadlifts and hip thrusts and all this type of stuff, and then you go and give them a bridge. I mean, that's just not going to do anything. If anything, you are going to be underloading that person. This person is not weak. The weakness is not their issue. The pain inhibition is more of the problem. But if you just then give them a bridge, that's going to be boring, not stimulating whatsoever. Yes, it's targeting the hip extensors, but if they're doing hip thrusts and things like that and not getting any hip pain, I mean, you giving a bridge is a waste of time. So on one end, flared symptoms up. On the other end, you may not have flared symptoms up, but you haven't stimulated the individual at all. So you've got to try and find that happy medium of trying to stimulate the person, make them feel they're getting somewhere and doing something, but at the same time not flaring the symptoms. Yeah.
And that goes nicely to the key targets of rehab. So what would be some key, like maybe could be a deficit or muscle groups, or based on obviously your assessment, functional testing, or handle whatever device you have, what would be your key areas where would you focus specifically on the strengthening in this patient group, Callum?
Yeah. I think the first one, and we see this with all intra-articular hip pain, in my opinion, Benoy, and every research paper I've read, it highlights this. It's the hip abductors, or we'll call it the lateral hip complex, which tends to suffer. And we find that with FAI, hip dysplasia, hip OA. So the hip abductors is normally a very nice place to start. A place I normally don't start is the hip flexors. Don't know if you agree with this, Benoy, because
Definitely. It's provocative, isn't it? To the capsule and anterior hip.
Yeah, and I mean, especially the dysplastic hips that have led to hip OA, where they're kind of iliopsoas, iliocapsularis ends up becoming a bit of a sling, especially if someone's got quite an anteverted femur. If you start chucking lots of hip flexor drills in, where we know the iliocapsularis in particular tends to hypertrophy, tends to get bigger anyway, that can actually lead to provocative symptoms. So I don't tend to go for hip flexors. To be honest with you, for probably at least the first couple of months, I'm probably not entertaining hip flexor work. I'm probably spending a bit more time focusing on hip abductors, trunk control, and so abdominals, the obliques, that type of work, working on stiff work as like a plank, for example, or a Pallof, but then we can go into a Pallof twisty. So we're looking at stiffness versus rigidity work. I also work further down the chain as well. So calves, I think, is a really forgotten muscle group, generally speaking. And I have this conversation a lot with sort of colleagues that I work with. When we've got someone with hip pain, the natural thing is let's target the hip. Let's get people stronger at the hip, which is absolutely needed. And that's why I think the abductors, the extensors can be quite a nice place to work. It is also appropriate to work on other areas, like the abdominals, like the quads, like the calves, and work further down the chain. So I don't know if you get this sometimes, Benoy. Sometimes you cannot prescribe very much riders for the hip because symptoms are just too irritable. But you need to start giving them something. So you work somewhere else. Start working on the
Yes,
knee work,
definitely.
start working on the foot or
Yeah.
calf. Well, just to yeah. Do you do that in your rehab?
Yeah, definitely. I think for you is looking at the whole, because most of another thing which reminded me, especially the chronic cases, sometimes they have bilateral weakness. So the good side is no more good. So they might have weakness on the other side. So only in the early phases will do bilateral, and definitely the trunk, the quads, the calf complex. So looking at the whole kinetic chain, because when they're going back to any sports, just getting that hip abductor extensors is not enough. You need to really get that. And I totally agree with you. Is the flexors and adductors are not a good place to start with initially, similar to FA syndrome, because it's quite provocative. But eventually, for example, you got a middle-aged male who is doing fireside football with OA, you must get them back into some form of adductor training eventually. But it's not, you're not going to stay on day one, because that is where they get irritated. So respect that irritability, that high level of pain, but try to get them more specific. And one thing which I'm sure like we'll discuss is one area which I find is ignored is looking at the capacity, like low impact cardio on other side. So what do you think is the importance of building up capacity, especially with things like walking, cycling, cross trainer, pull? In my opinion, it's very crucial in management of hip weight, not just strengthening. What's your opinion on that?
Yeah, look, I think cardiovascular fitness, cardiovascular training, just think doesn't get spoken about much in just
Yes.
as rehab in general. Anyone listening, feel free to message and happy to hear your thoughts on this. But not just with hips, but with anything. I feel like cardiovascular exercise doesn't get spoken a lot about when we know in the research, we know it's fantastic for pain modulation. We know it's great for general health and fitness and outcome, but it doesn't get spoken about a lot at all. So cardiovascular work is very important. And something that I wanted to touch on, Benoy, which I've made a little note on this because I'm hearing this a lot in the social media world. It's strength versus capacity.
Yes. Yeah.
I
You
think
want to
sometimes,
highlight that to the audience. Yeah. What do you mean by
yeah,
that? Because there's people use different terminology.
yeah, and I think sometimes they get used interchangeably, and they are two different things. And I want to use it to highlight something that I have seen, which often confuses practitioners. So I think we're all very familiar with strength, and if we talk about what strength is, it's the ability for a muscle to overcome a force. That's what strength is in a simple sense. Capacity is a little bit different. So what I've noted for capacity is it's the ability for the person. So not just the body, but their entire system, which includes the psychology as well as the physicality, to tolerate, to perform, to recover from whatever task that has been imposed onto them. So strength is, muscles contract, move a force over a certain time, and we talk about power, etc. Capacity is different. It's the ability for the whole human to do a task, the ability to tolerate, to perform, to recover from what we ask them to do. And the reason why I highlight that is because what I've seen a lot of before is that people get referred to me and they say, I've done all the strength work that I've been asked to do. And we've got a force frame where we work,
Yes.
which we do for the
Yes.
hips. Someone would have gone somewhere that there's been a force frame. They do the strength work on the force frame and their stats are X. And then 8 weeks, 10 weeks, 12 weeks later, they retest on the force frame. And I don't know, they've gained 30% strength in a 12-week period, but yet they've still got symptoms. They're still struggling with pain. They're still not able to run 5 kilometers. But it
Yes.
really confuses them because they say, but I've got stronger. So why can't I now run 5 kilometers? And
Yes.
that's where we say, well, they got stronger, but their capacity hasn't improved. And I
Yeah.
think that's a very, very important terminology to distinguish the difference sort of between. And where
Yeah.
Benoy, you mentioned about strength with load management, about building confidence, building self-efficacy, we mentioned in the last episode as well. All of that links into capacity. Me giving a hip thrust is designed to get the hip extensor complex stronger, but that's not the sole solution here. We have to think about the capacity of the human being, not just here's an exercise to target a strength deficit.
Yeah, and definitely that's where I think cross training is really useful. I think sometimes because you and me we're biased. I can give my personal example. There was not too long ago because, like you, I like lifting weights and I could lift quite heavy weights. But I have a chronic knee issue which I had a few surgeries, so I was struggling to walk more than 40 minutes. I mean, it makes no sense. I was deadlifting 110 kilos. I'm strong. Why I'm
Hey,
getting pain
not
with?
Benoy.
With the trap bar, yeah, with the trap bar, though, I find that works for me. And the problem here is not strength here because I've not done enough isolated work for my knee. I've not really been neglecting my cardio with my bike. So what I did was work more on the bike, a little bit of isolated work and more calf work. So sometimes people make this direct assumption just because you're smashing the strength markers, you can walk or run or cycle, and the body is more complicated than that. So generally look at the whole sort of mechanics. And we know also from studies that moderate intensity cardio can also have a big effect on sleep, improve sleep, and also can help in pain modulation. So it's like a low dosage painkiller. You're really helping with the pain modulation. When you sleep better, everything gets better. So I think cardio, you're totally right. For me, I think if you're doing any lower end rehab or any rehab, in my opinion, if you're not having good dosage of cardio, you're missing out on a lot of benefits, both physically and emotionally as well. So I think cardio is so important. And other points, there are few may not have time to go in depth, but there are a few other areas where I also touch. And fortunately, the group I teach, I deal with most of them. I do find in the NHS is a bit different, especially in private practice. Most of the patients are not overweight or obese. So we have to touch that as well. So weight management is important, sleep, and also other points is, for example, they're working in an occupational job, like they're plumbing, they're kneeling a lot or something like that, then maybe some changes there. So we have to look at the whole side, it's just not giving them some strength exercise. What are the other, is that something you touch as well, like weight, sleep, and all those sort of areas with the OA management?
Yeah, no, definitely. I think we've got to remember we're dealing with humans. We're not dealing with cars. And yeah, strength is one factor, but physical activity, and that's an important difference to make with people, because most people in the general population think that, oh, well, I've gone for a walk, so I'm exercising. It's like, no, you've been active. Physical activity doesn't have a structure. You've gone out to do something. You're doing the gardening. Exercise is more structured, and there's a specific purpose there, whether it's to improve your flexibility, get stronger, get a sweat on, raise your heart rate, etc. Physical activity doesn't do that. So we want a healthy combination of both physical activity, cardiovascular work, whatever they enjoy doing, as well as the strength work. But yeah, I say to everyone, look, whether you're trying to improve generic cardiovascular fitness or get stronger, none of that happens at the time you're doing it. We know physiologically, we've known it for decades, that it doesn't happen at the time you're doing it. It happens in the recovery. So if you can hydrate yourself well, if you can fuel your body well, if you can get good night's rest, that's where the game changing happens. If someone is carrying excessive weight, that's a very delicate subject, Benoy, isn't it? That's not normally something I would bring
Yeah.
up straight away.
Yeah.
I would listen to. Have you spoken to Ben before?
Yeah. I've heard his stuff where, he's doing the work on the knee OA, isn't it? Knee
Yes, doing his
osteoarthritis. Yeah.
PhD work. Yeah, his last name is completely blank to me now, but his name's
Oh,
Ben, Physi Nutrition, I think it is on Instagram,
yeah.
but he speaks a lot about this. And I think he's got some excellent ideas and concepts around these discussions. But for me, I often try to wait to be invited in on that conversation. It's not something I will bring up straight away. We know that it can take a few sessions for you to build a relationship and rapport with a patient. And normally that's the time maybe to try having those discussions. But I wouldn't mention it unless they bring it up. Because
Definitely.
sometimes will say, "Oh yeah, look, I know I've gained some weight, so I've been prescribed, Manjaro, for example, to help me lose some of this weight." They've invited that conversation in. They're freely talking about it. So okay, that's different. But if you've got someone that is overweight and it isn't mentioned, I would hold off for a little bit until you've got that
Definitely.
buy-in. You mentioned
Yeah,
earlier.
I think yeah, definitely. We don't want to jump in on day one, but I try to bring the conversation when people ask me is what are the things I can do to prevent it from getting worse. So I say to them, like, it's a holistic management here. We have to look at the exercise, the weight sort of thing. So you're totally right. You have to be invited, and people might find, the session one is not really the best time to really have that conversation or anything. And most people, the reality is, most people know they have a problem with weight. We don't have to rub it and make it obvious. It's not something they can't really acknowledge. But I think it becomes more clear for cases like knee OA, sometimes that people know that very clearly. And the interesting thing is with hip OA, which I'm sure, you must have looked on the research, which I was surprised is the relationship between weight and hip OA symptoms are not very strong, unlike knee OA. So I've seen a lot of patients, which have over the years, where they have lost quite a bit of weight, which is excellent, but the hip OA symptoms have not made a big change. Whereas I think with knee OA, it's like day and night difference. So they lost like 2 stones, the knee pain. So I don't know why that is. Where is it because of different mechanical loading? So sometimes we have to be careful. Then just losing weight might not solve the pain. puzzle,
No.
but it can help with systemic, they can work more, they can do more. It's always a good thing. So it's one little element there. And as therapists, we're going to guide them. And there's a lot of help, like even in the NHS, there's a lot of options like the weight loss jabs, counseling, and things like that. We're going to guide them there. But definitely look at the sleep. Sleep is something which we know is so important. And also looking at their occupational load. What are they doing at work? Are they sitting a lot? They're kneeling a lot? Are they very physically demanding? Can they make some changes? Or they're driving a lot? So definitely look at the whole element. Now, I think the last element which we want to go through, I'm sure we don't fix every patient. We don't, there's going to be a big, like, I would say this because I'm second opinion or third opinion. A significant number of my patients, unfortunately, they're beyond physio, and I have to refer them for surgical opinion. And there's a problem here where I see patients keep them too long, and because they're told they're too young, there comes to a point where physio is not the solution. They need to be referred for a surgical opinion, like, for example, hip replacement or injections. I'm sure we'll have a separate podcast on that where we can discuss into non-conservative options like hip resurfacing. So when would you consider that physio is not the option when I need to escalate to possibly a surgical opinion? What sort of things you look at from a symptoms, objective things, flare-ups and things like that? When would you have that conversation, Callum?
It's very dependent. I've had a patient 2 weeks ago now, mid-40s gentleman, bilateral FAI.
Okay.
And I'm helping him conservatively right now, but he's had pain for 10 years in both hips, sort of on and off. His right hip now is significantly worse. I've referred him for a surgical opinion straight away, initial consultation. He's had physio before. I think he's had 3 physios. I think it was over the last 10 years, and it helps a little bit. But I saw him for that initial consultation, and we had to have that discussion of, look, you've had this hip pain for 10 years, and you've seen 3 of my colleagues here in Australia, and it hasn't helped. So I'm not Superman. There's nothing magical that I'm necessarily going to be able to do here that's going to remove your pain and stop you needing surgery. But it was a case of, look, let me refer you to my orthopedic colleague so I can get his opinion on it. And I said, look, we'll work together now. Best case scenario, your pain does go away. Worst case is we are training you up for surgery so that we get very efficient outcomes after the surgery. So that was that was something that was mentioned first off, because it was 10 years of pain.
Of course.
You have to sit there and go, oh, but Callum, you're a hip specialist physio. And it's like, yeah, but look, we're not Superman. Yourself, Benoy, we're not Supermen. Some people, it hasn't worked, and it's okay. I think a lot of physios sometimes think that if we're referring someone for surgery, it means we failed or they failed, and that's just not the case. It really isn't.
And if you can fix everybody, then the surgeons will have a business.
Exactly. Yeah. We'd be millionaires as well.
Yeah. I think you're right. There's a couple of points I would add here. He's totally right. This is where I think experience comes in. Now, I've seen enough of these cases where I get a gut feeling where I know straight away that this isn't going to work, but I would give them a good chance. So because in my opinion, just you mentioned, it's not a wasted rehab, it's prehab. Let's say I've done 3 months. So I'll say to patients, let's give a good go for 3 months, see the response. If things are improving, we look at plan B. And this is where I think being very clear on that is patients know that you're not trying to fix them, or I don't give them, no one can give guarantees. I'll say, I'll do the best with what we have and the time we have. But if not, we can go into different options. But I look at 2, 3 areas. One is not improvement. They're not made, or the plateauing. You try to put the work, they're not really progressing. The second one is their ADLs is affecting more and more. They're really struggling with basic stuff like, walking, sleep, waking up at night. They're really struggling with travel, playing with the kids. So the daily life is getting really hampered. And also the other one is where they start stopping many things. They've stopped going to the gym. They've stopped running. They're not doing the classes. They become like a recluse. They've sort of, they're cutting down many, many, many things. And in my opinion, that's not the way to live when you're 30s and 40s. What's the fun? Like if you stop everything, what's the point really? You might always get a replacement. So this is where I think I looked at the ADLs. What's the training like? How is it affecting the sleep? And then I'll put the conversation. I say, see, we've done our best, and it's not a failure. It's not an accepting that you failed anything. And we know that one of the best treatment here is a replacement. And it's not like it's only going to last 10 years. We know it can be up to 25, 30 years with the right implant. It's not a failure, and you might have a better. So it's not like I've given up and it's a natural thing. It's the right thing to do. So, and this might not happen in one session. It be something you build it up and say, see, we've been in this for 4 months. but you're still struggling with 30 minutes of walking, you're still waking up twice at night, you're already on a lot of anti-inflammatory drugs, maybe we need to get an opinion. And I always say to people, I'm sending you for an opinion. I'm not sending you for surgery. It's a surgical opinion, just to give a bit of and surgeons sometimes might say, maybe let's wait for 6 months. But it's good to have an MDT, isn't it? It's not like natural that I'm sending for surgery.
Yeah, absolutely. And that was the case that I had when I referenced this patient a couple of weeks ago, is that I'm going to send you to my surgical colleague for a consultation, for an opinion.
Yeah. Yeah.
I'm not sending you for surgery. But it's worth having that because he had, hip pain for 10 years. But if I've got someone with a very acute and they've just started getting some hip osteoarthritic symptoms and it's been 3 or 4 weeks, then no, I'm not really having that conversation. Let's go for the conservative option. But some things that I'll touch on that you said there, Benoy. In the UK, I know this is different on service, but we used to use the Oxford Hip Score as
Yeah.
like a patient-reported outcome measure. And I think these things get underutilized because if we're
Yes.
talking about, they're declining in function, psychosocially, etc., we need patient-reported outcomes measures. At Perth, the surgeons that I'm working with, they like the IHOT 33. So that's
Yes.
the one that we use. And you use it at the start of your rehab. And if it ends up being 12 weeks, 16 weeks, do it at the end because you get a good measure then of where they're sitting in terms of their perception and things that they're doing. So that's something that I would add into the clinical reason on when am I referring on for surgery or opinions. The things that I think is worth mentioning as well is if people are functionally declining quite rapidly, but also if there is a change in either the intensity of their pain or the nature of their pain. So you start to think red flags. So if they start to get night pain, if there's a significant loss of quality of life, failure to progress without rehab, but if they start getting neuropathic changes, vascular changes, losing their appetite, nausea, so progressive night pain, feverish, etc. Screen for bladder, bowel, sexual function. These are all sort of other conversations that you and I can have, Benoit. But if stuff like that starts to present, then I'm escalating it very, very quickly. So it goes a little bit deeper into just, hip OA. We need to also look for, is there a change in the nature of symptoms, the nature of that person's behavior? All of that would warrant escalation as well.
Yeah, definitely. And the thing is, sometimes the problem of being a specialist is sometimes most of the time, people come too late. And there's very little you can add anymore what the good work done by other physios. So people, and that sometimes puts a pressure on me. People expect you to give something magical solution, and there's nothing more what it's already been done, So I don't have anything new to give, but it's just confirmation. But sometimes they find it good to hear from somebody that what they thought is true. So I always ask them, what do you think you've been thinking? And I think maybe I need a replacement. And I said, yes, that's the right thing. So many times they're coming to me for just confirmation of what they already know intuitively, and that's not a bad thing because it's a big commitment and it's a big decision, and they want to make sure that they're doing the right thing. Which sometimes the only thing you can do is to say, guide them and say, and this is where I feel discussions with other colleagues is really important. For example, in London, I work with pretty much all the top surgeons. For example, if I have somebody who's having a dysplastic OA, which is a bit more technically demanding, I know it's the type of surgeons to refer for. If I have somebody looking for hip resurfacing, then I can refer them for a particular surgeon. If they're looking for an anterior approach, posterior approach, we spend, I'm sure you spend time with consultants, so we sort of understand it's not like a hip replacement is just not a simple one procedure. We're talking about, there's so many technical aspects: anterior approach, posterior approach, robotics, cemented, uncemented, resurfacing, hip precautions. So that's a bit more technical. So that's where people like a specialist can give a bit more insight and say, this is a surgeon for that, and we can guide them appropriate to that particular surgeon. So even though I may not be able to help them in the rehab, I still give them some useful information on guiding them to so people think all replacement is the same. There's a lot of, variations and depth technical. I'm not a surgeon, but I can guide them to the appropriate surgeon to make sure that, people have a very general view of hip replacement. And sometimes some surgeons are not used to replacing below the age of 50. They're seeing more the elderly, and they might not want to do for a 36-year-old male. So do you link up with surgeons in that sort of different category, Callum, who sort of
Yeah,
have in your work practice?
yeah, definitely. I think of it in the same way of how us physios link up, don't we? I mean, you and I, Benoit, if there's a tricky hip case with where we work or the region we work in, people will say, "Oh, go see Benoit, go see Callum for this hip stuff,"
Mm.
right? You and I will see shoulders, right? We see everything, in clinic. Yes, we
Yeah.
see a lot of
But not a tricky, but if it's a complex shoulder, I'm not going to keep them, Yeah,
Absolutely. If
shoulder.
there's a
Yeah,
very tricky shoulder, I will need to lean on a specialist physio colleague of mine in shoulders, or if it's feet and ankles, So in the same way, surgeons are similar. I met up with a surgeon yesterday who very happy to do total hip replacements, doesn't like the preservation surgery. Or doesn't like it, maybe isn't confident with it, doesn't do a lot of it. So that's okay. So I've met up with a surgeon a few weeks ago that does all of that preservation
yeah,
surgery. He's happy on the replacement stuff. So that could be just the type of surgeries they do. But as you've broken down there, the type of preservation surgery, the type of total hip replacement, have those conversations and dig deep into exactly what they do. Get to know them and the guidelines that they want, if they have any guidelines. So I think we need to look at surgeons in the same way that we look at each other. Of
of
my
course.
physio league is a specialty here. I'll reference Jo Gibson, our shoulder UK consultant physio for shoulders. Yeah, she's the bee's knees if you've got a really tricky, horrible shoulder. But yourself, Benoy, hips, in where you're working. So I think we need to have that same approach with our surgical colleagues as well. They all have their niches, their expertise, their strategies, their methods, their guidelines. We need to get to know those so that we can
Yeah, definitely.
patients before they go and see them, give them an idea of what to
Yeah,
expect, can help
yeah.
settle
That's why I
anxiety.
think that's why spending time with them, like in the clinic, the theater, evening events. So I, make a big effort to link up because I want the best outcome for my patients, and also I want to guide them to the appropriate surgeon because the rehab will be easier for me if they have the right surgery. So I think that comes in nicely to sort of wrap up some of the key takeaways from this episode. I think the first is, I think possibly the most important is the language we use. So making sure that we are avoiding terms like bone on bone or you got the hips of an 8-year-old. They're not really neutral description. They can be extremely harmful, increase kinesophobia, reduce activity even before you start the rehab. So I think trying to keep a more holistic model of HIPOA, looking at the whole joint involvement, kinetic chain, and also it's something which we can have a positive influence with conservative management. And as physios, we are biased. The second point I would say is as physios, we're biased towards strength, but don't forget about capacity. There's a big distinction here. Look at the whole body's ability of the body to tolerate, perform, and recover. So looking at the cardiovascular side, looking at the weight side, looking at the occupational side. So we can't just be looking at just hip abductors and extensors. Look at all elements of hip wear management. And over resting is a problem. I find sometimes people shut down. People don't do enough because they have the fear of causing more damage. So we know that exercise doesn't do that, and we have to educate them that exercise is one of the best things they can do to delay the progression of OA, and also to stop people like activities like running. Patients, if people are have that background of running and they're not in a flare up and they have good strength and mobility, there's no need to stop them from running if they are being trained. So it might not be for everyone, but for the right person they can still continue with the running. And finally is also knowing when to escalate. Conservative management, unfortunately, will not resolve every presentation. It's not going to fix every problem. If you have persistent high irritability, significant functional decline, night pain, and failure to progress, then all this warrants surgical referral for an opinion. It might need further imaging. Sometimes they may need injection discussion, and surgery can be an important part of the conversation, and also referring to the right person who does with this sort of specialist group. So it's a more holistic management, and the best outcomes, whether it's conservative or surgical, should be driven by decision making and collaborative and not driven by fear. So that's what I think, in my opinion, those are the key points here. So exercise is the key intervention. And for me, I think, there are 3-4 key points I think as physios we can do well. Number one, use the right language, which empowers rather than alarms. Manage your load very intelligently, very be clear on a prescription, just like you do with drugs. And most importantly, finally know when conservative management has reached its limits, when don't hold them on too long. And sometimes surgery is the best option for many of these patients when they've reached that end point of their progression there. Any final thoughts, Callum?
I'm just going to link it to our last podcast as well, Benoy, for the final thoughts. One is that people are not too young to have hip osteoarthritis. You're not too young to have a hip replacement either. So we need to remove those myths. Ultimately, work with the human, don't work with the hip. You're treating the hip, but you're also working with the human. So just remember there is a human behind the hip.
Yeah. Excellent. So if you found today useful, please share this episode with a colleague, because the more we raise awareness of HIPOA and the management option, then it's going to be better for our patients. Subscribe if you're not done already, and follow us on socials. I'm on Function to Fitness, and Callum is on Hip Rehab Lab. That's where we share most of our clinical content, episode updates, and also information of our face-to-face events. So if you want to develop your clinical skills further in person, we run live courses. All the details are updated regularly. Thanks for listening. We'll be back very soon with more from Straight from the Hip. Thank you.
Thanks, guys.